vaginal prolapse is basically dropping of the bladder in the vagina, which is called cystocele, which is the front part of the vagina. And if you have the womb and the womb support structures are failing with, then the womb can come down below in the vagina, or in occasional cases can start coming out of your body. That's called uterine prolapse or the womb prolapse. Some patients who had hysterectomy in the past will have the top of the vagina which can come down, which is called vault prolapse. Similarly, on the back of the vagina, when the bowel is trying to push into the vagina, that's called rectocele or the bowel prolapse. One simple thing is obviously childbirth. So we have vaginal childbirth can cause trauma, which is trauma to the pelvic floor, which causes weakness and then predispose you for a prolapse. Often instrumental delivery, especially forceps, is known to cause a traumatic effect. Patients who have to strain for one reason or the other, either lifting heavy weights all the time or constipation, these are risk factors for prolapse. Then patients who go into menopause, so lack of hormones can make tissues weaken, and then they can susceptible to prolapse. Some people have born with a weakness in their connective tissue, which is what can be predisposed to prolapse, especially if patients are having prolapse at a young age. So that's maybe because of your collagen, which is your supporting structure in the body, which is constitutionally weak, which is genetically linked usually. Sometimes prolapse doesn't cause any symptoms. Some patients do present with bowel issues or bladder issues, like not able to empty their bladder well, or they empty and then they think that they're not completely empty, have to go back and empty the bladder. Some patients feel a chronic cystitis. Some people feel they take a long time to empty the bladder. For patients who have prolapse in the back of the vagina where the bowel is coming down, then they can also present as not able to empty the bowel well and may have to splint or support that area to empty the bowel. And obviously, if you have a prolapse which is uncomfortable, some people feel uncomfortable, dragging sensation. Patients sometimes describe as sitting on a ball. So those kind of symptoms are the common symptoms. Uncommonly, prolapses causes pain. They can cause a lot of discomfort. Some prolapses are easy to diagnose. Patients can feel the bulge. Sometimes it's coming out, you can feel it. But which compartment is prolapsing, front, middle, or the back, is usually with the examination. So examination, depending on how much prolapse you got, it can be done simple, like when we do a smear test. Similar kind of examination when we ask you to push and we have a look where prolapse come back. Occasionally we may have to examine a slightly different position or even standing up to diagnose exactly what extent of prolapse in the compartment is coming down. Optimizing your health conditions, like got high BMI, then it's better to control that first, reduce your weight, and if you are constipated, make sure that constipation is addressed. If you're lifting heavy weights, make sure that that's addressed, and you continue pelvic floor exercises. So this is the most conservative options of doing the prolapse. Some of the prolapses are quite big, and the conservative options don't work. In that circumstances, the second conservative option is a pessary, which is like a ring or comes in different sizes and shapes. So surgical options for the front wall, which is your bladder coming down, is a repair. Similarly, when your back of the vagina, which is bowel coming down, is a repair operation again. They both use stitches. And the womb is coming down, then options are either a traditional option of a hysterectomy, or you can restitch with a strong ligament called sacrospinous ligament, or you go through the tummy and put the mesh around the womb. So if you have bladder coming down or back of the vagina coming down, what we call is a repair. It's in medical language is called colporrhaphy. Basically what we do is we open the vagina, depending on where we're doing it, in the front or the back of the vagina, push either your bowel on the back or the bladder in the front back to where it's supposed to be and bring your native tissues together with the stitches, either the muscles of the back or something called fascia in the front. Bring it together with the stitches and then suture that part up. So basically we tighten your own tissues to give you better strength there. On the day of the surgery, you will find a catheter draining your waters usually for 24 hours, and a pack inside the vagina which will come out next day, and hopefully you'll be able to go home either on day 1 or day 2. We ask you to avoid lifting heavy weights and constipation, and we give you laxatives to take home. You shouldn't get heavy bleeding. Small amount of bleeding is acceptable. You shouldn't get heavy bleeding. Some discharge is quite common because the stitches takes around anything around 6 weeks to 12 weeks to dissolve, and during time they can give you discharge. You shouldn't be in excruciating pain, and simple pain relief like Nurofen should be more than enough. So vaginal prolapse can reoccur, and approximately, if you look into different literature, it says around 1 to 3 in 10 women will undergo a repeat procedure in 5 to 10 years time after this procedure. But what can we do to prevent them or reduce their chances of happening again is modification of your lifestyle.